All right. Just checking, can everyone hear me on the panel? Give me a thumbs up. Awesome. All right, well, we'll make a start. Just let everyone know that this is being recorded. So if this will be provided for people at the end of the webinar. But we wanted to welcome everyone along for tonight's webinar. We've got a really great webinar coming up, going through a little bit about early child's development. So what we sort of expect from very early on through to adolescence, and getting some important information around what some of the things that we should be looking for as parents in terms of what sort of is normal and what's not normal. And it'll be a special focus on lower limb and walking. So in combination with information from our special guest, Dr. Patrick Doube, who's a paediatrician, we're going to go through some really great information on some of the things that as parents or as carers of children, we need to know to ensure that obviously if there is something that we should get our child assessed, we have some of the tools and we can have a little bit more information about some of the things that we should be looking for. We're also going to go through footwear. And I know this one's a big one for a lot of parents, really concerned about or confused about what we should be looking for with footwear, particularly in children and particularly at different ages and stages. So the information we're going to be providing is a little bit about what the sort of the latest advice is around footwear for children. And we're really lucky to have Paperkrane along with us. So we've got Zara and Kate from Paperkrane, who are a Melbourne-based company and do some really great, fun, fashionable shoes for kids. And we're going to chat a little bit and find out a little bit more about what their shoes and their brand is all about. So a bit about me. My name's Andrew Maitland and I'm a podiatrist at Melbourne Podiatry Clinic. We've got a couple of clinics, one in Essendon and one in Blackburn. Our clinic very much specialises in foot and lower limb pathologies. So people who present with certain foot and lower leg injuries, whether they be from occupational sport, but also we have a strong passion and interest in dealing with children and that developing child. So having a bit of a look at what some of the things that present in an early age and obviously dealing with them. Like to introduce our paediatrician, Dr. Doube from Melbourne Podiatry Clinic. Patrick is a paediatrician and he works in the special care nursery and also has private rooms in the North Park in Bundoora. And also works at the emergency in the Austin and Northern hospitals in the paediatric department, and has a special interest in developmental paediatrics. So really relevant to what we're going to be talking about tonight. And he's going to have some great insights, sort of delving in a little bit more into some of those things that we as podiatrists may come across, and when we would refer to a paediatrician, a little bit about what they are looking for. So tonight, we're going to go through the sort of understanding the normal age and stage development in children. So trying to understand, I guess, what is normal and understanding a little bit about those milestones in children. What some of the things we should be looking out for. So signs, and these will obviously differ at various stages. What shoes are appropriate for children. So a little bit about some of the features and a little bit of discussion around that. And we're, as I said, very lucky to have a chat to Zara and Kate from Paperkrane Shoes to discuss a little bit about what, I guess, where shoe development is going and what their brand's about. And then we will have the option at the end for any of you to ask some questions. We may not get to all of your questions, but please do put them in the chat box and we will get to them. So if we don't get to them tonight, we will have them, and we will, if they're directed to the Paperkrane guys or myself or Dr. Patrick, we can obviously answer them, and we will email you a response. So please do if you have any questions. Just a little quick disclaimer, just before we get started. Obviously, the information that we're giving tonight, the advice that we're giving is general in nature, and obviously doesn't substitute individual advice, diagnosis, or treatment from a health professional. So we obviously want to provide you with as much information as we can, but if you do have any concerns, then I would strongly suggest you do go and seek out either an appropriate health practitioner if you're concerned or you've got any further questions on your child's or someone else's child's development. So tonight we do have some prizes. All attendees Paperkrane have very generously donated $20 voucher towards their shoes for all participants or for all attendees tonight. We will send you the code at the end of this evening that you can access. Jump on their website and use that code. We're offering 2 assessments at our clinic. So again, if you've got any questions or concerns, most of the time we're obviously going to go through just a history and a detailed assessment. Gives you the opportunity, if you do have that, to take that up. And we do one of the main prize tonight is that we have a pair of the really cool fashionable Paperkrane shoes up for grabs. And to win that, all we ask is that throughout the webinar, we'll be putting up letters, and make sure as the letters come up, you write them down. It will spell out a code word at the end. The first one to chuck it in the chat box will win those shoes. So make sure, pay attention when the code word comes up, make sure you write it down. So first code word, or first letter, is C. All right, so we can tailor tonight's presentation a little bit more to the audience. Can we quickly, in the chat box, can we get you to pop some of the ages of your kids in, so we can have a bit of a look, so we can have a bit of an understanding. So just in the, I think it's the Q&A section. Let's see if I pop that on. Oh, here we go, the chat. Yeah, perfect. Yeah, in the chat. Okay, so we've got 10 months, 2 and 4, 10 and 7, 6 and 7, 4 and 1. Okay, 10, 8 and 4, 4 and 6. 13 months. Okay, excellent. So it looks like the majority of tonight's guests have children that are around that sort of early child developments, which is great. And I think the information we'll make sure is sort of tailored a little bit sort of from that 0 to 10 age mark. But a lot of it will be, won't necessarily be unique to a certain age group. So, but thank you very much for that. Okay, so just to start us off, a quick quote about children's feet. Children's feet are not little adults' feet. So they're not miniature versions of adults' feet. And I know sometimes kids' feet are cute and you want to put them and dress them in little adult shoes, but the fundamental design of a children's foot is quite different, and therefore some of the things that are appropriate for an adult, for a fully developed foot, are not necessarily appropriate for a child. And that can obviously be simple things like the actual structure of the foot, but it can also be related to the fact that the child's obviously developing a lot of skills, and simply walking is one of them. And that is really important to consider when we're looking at, putting shoes on feet or children's feet, or thinking about some of the things, in terms of child's development, that we do make sure we take that into consideration. So that probably prefaces a little bit of where we're going with some of the information tonight. All right, next letter, H. Okay, so I'll get you to unmute yourself, Patrick. So we wanted to start with a little bit about what do we assess and what do we sort of expect to see with a child as they develop. So here's a little picture which I'll go through shortly, but this picture really nicely explains what happens with a child as they develop. And it's something that may appear abnormal at a certain age may in fact actually be normal for that various age, and something that may appear sort of normal is actually abnormal at that certain stage. So this gives you a really good explanation of how much a child changes. So you can really see from 0 to 18 months, we're getting quite a sort of a wide angle of gait. And if you were to see that in an adult, you'd actually be quite concerned regarding their knee health. But when we're seeing that in a 0 to 18 month old, that's completely normal. So what you can sort of see is that 18 to 30 months, we start seeing things tend to move inwards. In fact, almost by 3 to 4, it looks like it's overcorrected. And then as the child gets older, things tend to sort of rotate and straighten up. So it gives you a good little explanation of what we can see. And that's basically if you bring a child in to our clinic, that's some of the things that we look at is, someone might tell you, oh, look, we're really concerned that your daughter's knees are significantly rolling in. She's really turning her feet out. But that may be normal for that age. So around the sort of the 4-year mark, that may be something, and it might just be a case of us keeping a bit of an eye on it. So when someone comes in, a full history is really, really important. So this is not just about, walking and things. This might be things like gestation period, any complications at the time of birth, their APGAR scores, so the tests that they do immediately after birth, any developmental milestones, and their social awareness and their development. Milestones, I'm sure everyone's been told a little bit about milestones, when a child expected to be walking. These are tended to be used as a bit of a guide. So we use these as a bit of a range, and it's really only if a child is outside of those ranges that we start looking at trying to understand why. So often, people are expecting their child to walk at 12 months, but really from our point of view as clinicians, if they're not walking to 18 months, we're not overly concerned until it gets to that 18-month mark that we might start looking at investigating what some of the underlying reasons. So when we're using milestones, we want to know them. We want to know, and I'll bring them up. We want to know, when the child started rolling, sitting, crawling, walking, jumping, and running. And obviously, depending on the child's age, it'll depend if these have occurred or not. But these just give us a bit of an idea of the child's development. There's no hard or fast rule here in terms of if these are, not occurring within a very tight time frame, but we can get a bit of an understanding of that. And the other things we tend to look at is looking at the range of motion, and obviously if we're focusing more on the lower limb, looking at what some of the range of motion is. There some hypotonicity? Is there tight muscles? Is there some changes? Is there hypermobility? All of these things tend to get looked at. And muscle strength, tone, and reflexes. So I'll sort of bring you in, Patrick. Is there anything you'd like to add in terms of, as a paediatrician, if someone comes in to see you, what's a sort of an average consultation look like for you?
Yeah, so when people come and see me, I've got the luxury of pretty long appointments at the moment. So I do like to find out, what's the current situation for this child, which also means what's their family situation, what's their education situation, and what's their environment. But I think one of the things that I love about pediatrics, and particularly developmental pediatrics, is just what Andrew said, and that's what is the story of how this child is growing and this child is learning, and with a view to what's happened in the past, to what's going to set them up well for the next phase and the phase after that and into adulthood. So so I like to find out. I spend probably too long talking about what's happened in the past, and what happened in what was the pregnancy like, what was the birth like, And then exactly those milestones that Andrew's highlighted, I spend quite a lot of time going over those, particularly with relation to feet, these gross motor milestones, when they occurred, what order they occurred in, and did they sort of, come in the right sequence, and putting that into my knowledge, just like Andrew, our knowledge of what is typical development, and if this is atypical, is it something that needs intervention or just monitoring? I think that Andrew has certainly got a bit more expertise in, the particular range of motion and tonicity. But and then after a thorough history, a thorough exploration of what the concerns are at the moment, we move on to a physical assessment, and depending on what we find with our physical assessment, and then gait analysis. I think Andrew does that probably a bit more thoroughly than me. And subsequent to that, we can have a look at, are there any investigations and things we need to move on with, which I think is actually our next slide. But
Yeah.
just to reiterate what Andrew said about, our experience of being parents is pretty tough, and there are lots of neighbours and other people in the playground and aunties who chip in with reassurance or concern about what we worry about for our kids. And usually this is fine, but every now and then you'll get some auntie who says, my boy didn't walk till he was 5, which is not great. Or they'll say, your 2-year-old shouldn't be throwing a tantrum, whereas that's sort of what 2-year-olds do. And so a huge part of what Andrew and I, when I see kids, what we see is what's within this development. And if we've got a 10-year-old who's got, just like in this picture, a 10-year-old who's got legs that looks like this 18-monther, then that's a concern, even though it's exactly the same thing that is completely normal at a different stage. So as parents, when we're sort of getting from meal to meal and day to day, I think seeing people like Andrew is pretty helpful to be able to just answer that question, is this something to be worried about? And that's probably the majority of what we do. And if it is something to be worried about, it's sort of like, what can we do as health professionals to help create the opportunity for this child to naturally follow their intuition, their skills and their strengths to achieve what's going to make their life a bit better. So I think the next slide is a bit more about what we actually do to do that.
Yeah, so I thought I'd just quickly, though, talk about a gait assessment, because that is something in terms of lower limb development that can be almost like the detective work that we can try and then further investigate. So one of the things that we want to have a bit of a look at with a child is their walking, because it obviously can show us or tell us a lot about how a lot of these things may be occurring. So, it may be something that we then can further investigate if we're seeing some asymmetry, we're seeing some limp, or we're seeing some restriction in the range of movement. We can then obviously assess it. So a really simple gait analysis can be a wonderful way to just tell us a lot about the child, and can really help sort of plan where the next steps, where we might be going with some of the next steps. So yeah, then we tend to look at, obviously, as Patrick said, we kind of look at what some of the normal ranges, and I always put normal in inverted commas, because normal there is no normal. Everyone is slightly different. That's why these are ranges. It's not saying, look, if you're not walking by 12 months, we need to be, putting you in braces or trying to do, weekly occupational therapy. This is not what we're saying. We're saying, look, these are the things. And as Patrick very eloquently said, I think it's trying to give the child the best opportunity to be able to fulfill that potential and develop as normally as possible. And really, a lot of the time we monitor. It's just keeping an eye on things. And if things are going a little bit slower than normal, and then next time we catch up, things are sort of caught up, that's what we're wanting to see. And that's a big part of what we do. So in terms of some of the treatment we offer, again, monitoring and reviewing regularly are two of the main things that we do to just ensure that if we're not seeing something occur quite the right time frame, that we just check in a couple of months' time to see where that child's at. And if we're seeing that some things are not quite on the right track, then we might look at involving getting some exercise-based or occupational therapist involved to try and encourage this child to maybe do some different exercises, activities to try and improve they're walking. On occasions, we may look at certain splinting, bracing, and orthotics as a way to try and sort of encourage some development. We need to determine if there's any further tests that need to be investigated. And obviously then referring to the appropriate subspecialist doctor to try and obviously investigate what may be causing a particular issue, and obviously having a team that's got a good understanding of that is really important, and referring to other health practitioners. So if there's something is needing to be done, we know who we can obviously refer to get that sorted, and obviously advocating for funding if that's required. All right, so common pediatric lower limb pathology. So I thought there obviously are a number, but I thought I'd focus on the ones that we see the most in the clinic. So these are the ones that parents typically bring their children in. They're concerned of what might be happening with their child, whether their childcare educator has said, you really should go and get that assessed, whether their grandmother has said, I don't like the look of those flat feet. All of these things, or the parent is just a little bit concerned about something that they may have observed, or the child might be complaining of something. And that's obviously a really good and important reason to bring the child in. If the child is consistently complaining of something, children are pretty, they're not going to necessarily sort of pretend too much. If something is sore and it's consistently sore, as health practitioners, we do get a little bit concerned. So that is a really good reason to bring your child in. So the 5 things I'm going to go through tonight is in-toeing, something that we've probably all seen in a child, or maybe our children in tow. Toe walking, and Patrick's going to go through a little bit about when this may need to be further investigated. Metatarsus adductus, I'll explain what that is. Flat feet, that's something that we obviously get queried, probably the most common issue we get queried, and growing pain. So again, really common, and we want to try and explain when you need to obviously seek professional help if the growing pains are showing certain signs. There are some other issues that are sort of quite common: hip dysplasia, leg calf Perthes disease, club foot, and gross motor delay. We're not going to focus on them tonight, but they are things that really, if we, as health professionals, we will certainly be looking to determine if any of those are happening. Most of these are going to get picked up in the very early stages. So in Australia, we're very fortunate that you're going to have a paediatrician see your child in the early stages, and they're going to hopefully detect this most times. Cool. All right. Well, I'll start with in-toeing. In-toeing's a very common condition with children. It can be a little bit sort of confronting when you see a child, particularly if it's quite significant. It can be classified as either normal or abnormal. So normal can just be a normal variation in development, or abnormal as in there may be an underlying cause. And that's probably as our role is to determine whether it is normal or whether there is an abnormality there. And that's obviously going to be further investigated. So again, really, really important that we understand the child's history. Trying to understand, as Patrick said, a family history. Is there a family history of this? Is the child had any issues around birth? Is there any pain? Is the child suffering any pain? Are they not wanting to walk? Are they wanting to be picked up regularly? All of these things help sort of understand if there's anything more going on. So obviously we do a full assessment. We have a look at the hip range of motion, the knee range of motion, looking for things like hypermobility, where this in-toeing is coming from. Is it coming from at the foot and ankle level? Is it more through the lower leg, the tibia internal rotation, knee internal rotation, or femoral torsion? So the rotation of the femur, all of those things, we sort of want to try and establish where that's coming from, because that can help us obviously understand how we can address it. So we check things like the feet knees and hips as part of our assessment. 10% of children in toe, so 1 in 10. So it's quite common, well, very common. So a lot of children in toe. The severity can vary, but that gives you a bit of an idea of how common it is. But by 16 years, 87% has resolved, and only 4% in toe as adults. So you can see that with 1 in 10 in toeing as a young child, most grow out of it. And really, that's quite reassuring for people. The main issues we tend to see with in-toeing is that the feet get in the way. So the child can become a bit clumsy because the feet are turning in. When they're running, they might catch the other foot and fall. And that obviously can significantly impact confidence, wanting to be active. And so obviously, a parent can be a little bit concerned and want to have it assessed and resolved. But generally, we can be pretty reassured that the majority of cases this does resolve. One of the things that I'll just draw your attention to is W sitting. So a lot of kids who do in toe tend to W sit, and we want to try and discourage that. So W sitting is basically where the child sort of sits on their knees with if you look from the top, there's a W like this picture. With W sitting, the issue tends to be that it does sort of force that hip into internal rotation and can actually cause the hip joint to develop like that. That obviously, if you're internally rotating, you're going to cause those toes to rotate in. So we discourage kids from W sitting. We ask the parents to try and discourage their children from doing it. We even extend that to asking their childcare educators or their kinder teachers or their teachers to try and ask if their child during class, during childcare, can sit cross-legged, legs out in front. We do tend to see this a lot, and often it's a position that often a lot of children, certainly as adults, don't find this position comfortable, but it's with the hypermobility, they can sit in that position quite comfortably, and that can go hand in hand with in-toeing. So really, as health practitioners, we tend to only treat when in pain, or whether it's affecting function or causing limping. Affecting function can mean it may be inhibiting their ability to run or play, and that is a reason enough to look at providing some treatments. Generally, the treatments are going to be more exercise-based, maybe some stretching. On occasions, we may look at adding an orthotic to try and help encourage the foot to recover. So it's not necessarily splinting or trying to restrict the foot, but it can just help sort of retrain that foot to move in a more straight direction. But most times we're pretty comfortable that as long as we're seeing it slowly improve, and again, comes back to monitoring, we're pretty comfortable that in-toeing will eventually spontaneously involve. So that, again, monitor and exercise management. And look, some of the exercises might just be a bit of some fun activities that we get the parent to do with their child to help kind of get that foot to kind of rotate out. So toe walking.
Andrew, could I say something else about W sitting as well? Because I think that I think that I see this quite a bit, and I feel that hypermobility is quite a big contributing factor when kids are W sitting. There's a big spectrum of who's got, who's double jointed and who's not, and who's got Ehlers-Danlos syndrome or not. And there is a spectrum of people who are just a bit bendy, and particularly girls with bendy arms or bendy knees. And this can be normal. W sitting, if that's the only way the child sits, they should be encouraged to take other positions as well, because it's actually a really stable position, so it's really easy for the kids to sit in that. Whereas if you're doing crisscross applesauce or lying on your tummy or kneeling up, kids have got to use their core a bit more, and that's probably better for coordination in the rest of their body. So if it's the only way the child sits, then that can be a problem. But just encouraging those other positions is not only preventative, but can also be therapeutic in promoting good tone and good strength in the other parts of their body.
Yeah, that's great. All right. Well, this one's definitely where I'll get get you to jump in as well, Patrick. But toe walking is again a very common thing that we tend to see in the clinic. So it can be normal, as in it just can be a normal variation. And Patrick's going to chat a little bit about things like sensitivities and things which can be quite significantly involved in this, or it can be idiopathic. And basically idiopathic means unknown. So the child feels more comfortable walking on their toes. And once we rule out any underlying issue that may be contributing to that, whether there might be some calf tightness, ankle joint developmental issues in terms of restriction, or involving the paediatrician to discuss any other pathologies, which Patrick will chat about. It's just labelled as idiopathic. And idiopathic, again, as I said, it just means that there isn't an obvious cause. And as long as we can understand that, as long as we have ruled out those concerns that we obviously need to address, this is just something that we may tend to see, and then typically we'll see the child grow out of this. So it can be considered normal in the ages of 12 months to 3 years. Once we start seeing it after 3 years, it does set off a few little alarm bells, and that's when it is certainly important to go and see a paediatrician about this. As I said, it's important to rule out any known causes. And again, generally what as podiatrists we'll do is we'll do a detailed assessment. We'll have a bit of a look, as I said, if there's anything underlying that might be contributing to this. If it's completely reducible, and if we just ask the child to walk normally and they can, then we just tend to monitor it. If we detect that there's any red flags, then we will refer to a paediatrician to obviously rule out that and investigate a little bit further. So what we do, we conduct a video gait assessment. We look at the ankle function and range of motion. We assess reflexes, discuss with the parent and about things like hypersensitivity. And obviously we have a good understanding of the child's history. So I'll bring you in, Patrick. Tell us a little bit about if you see someone or someone brings their child in who's toe walking, what are some of the things that we need to, or you'd just be discussing with them around what they need to be looking for further investigations?
Yeah, sure. So I think that, starting with what's considered normal, I was just chatting to the parents of a baby who's 9 months old in my clinic today, and doing a neurological examination was able to show that this baby has quite healthily lost some of their reflexes up to about their chest, but still has some of their primitive reflexes below. So they've got some things that I can detect and show that shows that this baby's neurological development is normal, because you sort of have to lose these reflexes to be able to take over voluntary control over them. And that process quite commonly goes from top to toe. So it was quite nice to be able to show that to this family. I sort of wish that I had some students around to show, because it was pretty cool. But I putting this in the context of when it's normal is that that's the other thing this baby was doing with her hands, was starting to do these really beautiful fine motor things with her fingers that her parents thought looked quite unusual. But this baby is just developed from having sort of a palmar grasp to a more developmentally sophisticated pincer grip. And that's probably a similar sort of analogy to what in typical development, what's happened is that these babies, they've just started walking, they're trying to figure out where should my joints be and where should my foot be and where do I get the most lift and how do I go the fastest and what makes me fall over. And, part of that is putting, the strength on those metatarsal heads and seeing what it feels like in the joints, what it feels like on the skin. So in those age groups, it's quite, it can be quite normal. But a lot of people, but we do see kids who have got cerebral palsy, occasionally muscular dystrophy, and not uncommonly autism. Part of the checklist for these sorts of things is similar to that, thorough assessment that we do, looking at family history and perinatal history. Although I think it is important to note that, so family history quite important for muscular dystrophy. For cerebral palsy, there's been, it's sort of Australian research that has pushed us away from looking at what happened at the birth as a significant contributor to cerebral palsy. It was actually Fiona Stanley, one of Australia's probably most famous paediatricians, who did a lot of work to say, well, actually kids who've got cerebral palsy, most of them, it was something that was going to happen anyway. And it wasn't really related to how they were delivered and how they were born. Although obviously in some extreme cases it still is. Anyway, finding out all of those things is quite useful. And then autism, I think that the important thing to say is that, I saw 3 kids today with autism, none of them toe walked, and I did see one chap who's got idiopathic toe walking who does not have autism. So just from what I've seen today, there is zero correlation. When it does correlate with autism, it's probably part of sensory preferences, which when I was studying to be a doctor, to be a paediatrician, was, if you've got heightened sensory preferences, that's one of the diagnostic criteria for autism. But that's not really true. Like, we've all got things that we like and don't like. I, for instance, hate the sort of paddle pop stick thing that the doctor looks at your tonsils with. Just sort of gives me shivers. I don't really know why. But we've all got little things like that, the sensation we don't like, and some people don't like walking on sand. Some people are thinking about their ears. Putting that on the spectrum can be one part of an autism assessment, but really what mostly autism is in the setting of toe walking is, how does this child communicate with the world? What's this child's social skills like, and what's their non-verbal language like? So I think that I see quite a few. So and there are really good checklists, particularly out of La Trobe Uni. There's one called AS Detect. It sort of goes through at different ages. So they've got one that even starts at 6 months, and you can say, I'm a bit worried my child's doing this funny thing, or they're waving their hands in a funny way. They've got a checklist that can sort of give you a traffic light system of, green, you're fine, yellow, oh, just see how he goes, or red, yeah, maybe you should get him checked out. And it's got that at 6 months, 12 months, 18 months, 24 months, and can actually give you a trajectory. So we can share that link. That's called AS Detect. But I find that that's quite helpful to have something you're like, no, we've looked into it, I've spoken, or, talk to your GP or your paediatrician and say, well, is this something that we're monitoring or something that we're not worried about? And I think that putting that in the context, putting toe walking in the context of autism is important. The other part of what those sensory preferences are, I was going to say before, is I think Andrew probably sees quite a lot of this, is kids who either have, more sensory hunger. So they like really want to feel things because their appetite for it is a bit more. So I know that, my daughter's a bit like that with sand, but so you can't go near sand without her taking off her shoes and really getting into it. But there are some kids who might be the opposite, and they're not hungry for that sensation. So they will avoid it and stand up on their toes so that they're not getting as much sensory input. And this can be normal, or it can be part of, another sensory pathology. The reverse is also true if a child is really, likes that sensation of having the air around their feet, or, or another sort of, there's another sort of sensory seeking behavior. They might really like what that sensation is, the tightness in their calves. And so they like to walk on their ankles. I've seen a couple of kids with quite good verbal skills who have autism. And I say to them, what does it feel like? What can you use your words to tell me what that feels like? Say, it just feels good. And which I think is quite a nice way of looking at this. And then, but once again, what does this all mean? If it's in the global context of atypical development, we can look into it. But if it's not causing this child any harm, and it's not causing them any pain, and it's not affecting their gait, quite often we can just use it to learn a bit more about what our kids are into.
I think that's great. I think, as I said, it's important to obviously know that, you know, every child develops differently, and not just developmentally in terms of the milestones, but also things like sensitivity to different sensations and things. And toe walking is a really good example of that. So again, we do refer to a paediatrician if this is not resolving within that sort of early few years of walking, or if there are any other signs. And obviously, most cases, as Patrick said, it's just a case of going through what some of the signs are to try and obviously come to a diagnosis. So the next condition we chat about is not as common as the first two, but it's certainly one that parents want to discuss. It's called metatarsus adductus. Look, we are very lucky in Australia that generally this is going to be assessed very early on. And again, if your child sees a paediatrician in the early stages of their life, they're probably going to have this assessed, and generally very basic treatment can be provided. Occasionally, and we've seen it in people who are born outside of Australia, they may actually have advanced cases of this at a much older age, and therefore obviously the treatment does change. But this is basically metatarsus adductus is a sort of a C-shaped foot. It's where the metatarsal bones, so those bones, the toe bones, basically deviate inwards, like that picture. And the really simple test that we do is just basically grab the child's foot between our thumb and finger and have a bit of a look at the deviation, and if we're able to reduce it. So are we able to basically straighten that foot? More often than not, it is reducible. It's just they've got some developmental turning in. Can often be related to the gestational period, or how basically tight they were in development. And when, as clinicians, we just look at assessing the level of severity. So there's sort of 4 stages that we go through. Type 1's sort of very mild, does tend to sort of reduce, tends to spontaneously resolve, up to type 4, which may require surgery. Most often, though, we can address these stages early with things, so obviously diagnosis, but with things like massage and stretching. Occasionally, we need to look at some shoe modifications at certain ages if we're still seeing this persisting once they start walking. Some simple splinting and casting techniques to try and correct that foot posture as it develops. And very rarely do we need to look at surgery, but that is certainly an option if we're seeing it at a more older level that this is not resolving. Again, most cases, if are tend to be detected early. As I said, particularly in Australia, where we've got such a great healthcare system, and they tend to resolve without issue. This can be commonly confused with clubfoot. So a lot of parents, when they do see it, may be a little bit concerned that a clubfoot, it is different. It only occurs in that one plane rather than sort of a rotation downwards that occurs in a clubfoot. So that may be a simple reason to, obviously, if the parent's concerned, we'll be able to look at that and assess that and determine if there's anything more investigation. So it's probably the reason where parents are a little bit concerned that it may be an undetected clubfoot, and then we can obviously do an assessment of that. So make sure you're keeping writing the letters down. Got the letter A. Good. All right. So we've got 2 more conditions to go, and then we're going to have a little chat with the Paperkrane crew. Flat feet. I'm not going to spend too much time on this because this is by far and away the most common condition we provide assessments for. I think the number one thing I want people to take away from this is that it's not a pathology in itself. So unlike some of the other things, they describe obviously what's going on. Flat foot or flat feet is not actually a pathology. So a lot of people have been diagnosed with flat feet. Yes, that may be the case, but it's not a guaranteed predictor of anything. So It can be in extreme cases, we may need to assess it. The vast majority of the cases are a case of, look, this is just a normal variation. It's the most common cause we assess children for, and there has been over the years a bit of confusion around when to treat or not, and I'll go through that. The paradigm has changed over the past few years in terms of when to treat, and what we're looking at in the adult population, around sort of 60+% of the population have what would be classified as a flat foot. A very small percentage of those actually have related pathologies. So just because you've got a flat foot doesn't mean you need treatment. And obviously the treatment that podiatrists in particular have used is orthotic. So just because you've got a flat foot does not mean you always need an orthotic. And we've created, there's been some great study by a paediatric podiatrist, Angela Evans, who ran a study on creating a bit of a traffic light system on when to treat flat feet. So green light means no treatment. This is a normal asymptomatic, so no pain, no problems, flat foot. So the child just presents with a flat foot, but they don't have any underlying pathology. And this is also really important to remember that, you know, a young child, which is a 2-year-old, may have flat looking feet, but that's just the fact that they're a 2-year-old and that's what their foot looks like at that age. So still doesn't mean if you've got some concerns, we can obviously do an assessment to it. So it's not as simple as obviously like, you know, there's nothing going on here, but this just gives you a bit of an idea of what our thinking is around it. An amber light may mean that the foot's asymptomatic, but there's a non-developmental flat foot. So it's a little bit out of the ordinary. It's a little bit more on the extreme end. And there may be some gait issues going on, or the child might be sort of starting to fatigue a little bit. That means we may more than likely just monitor it. The last one is the red light. This is when we're getting a symptomatic flat foot. So as I said before, if we're seeing a child who's in pain, we do want to obviously look at addressing it. And there are a range of treatments. Orthotics are one of them. Lastly, the condition is growing pains. Again, this is a really common one that parents get a little bit concerned about. And really, growing pains are something that we want to rule out and make sure there's nothing else going on. So growing pains can be a normal part of development, the growing. It's not actually well understood what is causing the pain, but growing pains were typically described as an ache or throb in the legs. It's often in the front of the thighs, the calves, or behind the knees. It generally tends to occur at night. It tends to affect both legs and may even wake the child from sleep. So typically we're going to find a child who wakes up in pain, and that's sort of a similar factor with people who are suffering growing pains. And although these pains are called growing pains, there's actually no evidence that growth hurts. So again, it's not well understood why some children suffer growing pains or not, and perhaps we need another phrase. But at this stage, growing pains is that sensation that a child may feel that, if diagnosed as a growing pain, typically means that there's no underlying cause to the pain. Treatment tends to be just a heat pack, massage, stretching. Symptoms tend to go away. And that's where it's really, really important that if we're seeing symptoms persisting, if we're seeing the pain occur during the daytime, if it's only occurring in one leg, the symptoms are progressive. So we're starting to see them perhaps advance or continue, or they're suffering a limp. And that's your cue to obviously just go and get it investigated. Really, growing pains is one of those things that it's in the absence of anything else going on. So obviously if there's some of those symptoms below occurring, that's when you should go and chat to your... All right, so I'll get Patrick to jump on this, because this is something that I'll get you to quickly go through. We've got about, we'll probably start the Q&A with Paperkrane in about 5 minutes. So, 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 5 minutes these are just the movement guidelines. I'll get you to chat a little bit about them, because I think this is some really great information about, in terms of when we should be playing with kids, and a little bit about what the sort of the recommendations are to encourage normal child development.
Yeah, these guidelines are from, thanks Andrew, these guidelines are sort of Australian national guidelines based on some Canadian work that was done about 6 years ago, and these were done in 2017. And it's sort of part of a general health thing for adults, but then sort of as paediatricians, we were like, well, before adults are adults, we can start some good activities. So, but the whole idea is this, because of tonight, like why have a good shoe? And I think that for most of the age that the people that, that all of our kids are, mostly preschoolers, we want our kids to be active. And we just know this because we know that it's good, but there's actually pretty strong scientific evidence that if children meet these guidelines, they will sleep better, they will have better mood, they will learn better. And one of the things that I think is important for a lot of people, particularly in our current climate with, viruses getting a pretty bad rap, and also a lot of the common viruses that preschoolers get, we didn't see much of last year, and they're coming back with a vengeance this year. So like croup and bronchiolitis and those sorts of things, we're seeing a huge number of cases over and above what we would normally get. So hopefully by next year, it'll be back to normal. And it's just all the kids who didn't get the viruses last year are now meeting them and developing some immunity to them. But more than really any medicine or supplement or anything else, activity is really good for your immune system. And there's good science behind this out of the UK and Canada. So these guidelines are to make, not just, to keep your kids busy, but these will keep they keep our kids healthy as well. So I'll focus on the first three, and this is just my summary, and we can send you out the link. But essentially under 12 months, kids should be having as much tummy time as possible. This is really good for their tone, really good for their neck movement and stuff. I see a lot of families where tummy time is really hard, and I know it was for my son as well. My daughter loved it, my son did not. But I see a lot of families where the kid's on the ground, but there's nothing fun for them to do there. And so that's why I put this picture over here with the mother and the baby on the ground together. Go to grounds, be there with your baby as much as possible. Another thing that I was quite taken by with these guidelines is that really no preschooler should be restrained for more than an hour at a time. Now, my daughter has actually driven from Melbourne to Adelaide today, so she has failed that one today, being restrained all day. But I think in general, if we're planning our days, kids should be moving. Kids shouldn't be in a pram or in a booster chair for more than an hour at a time, because they need to be able to stretch their muscles so that they, so that they can grow properly. In the older kids, the activity guidelines are that kids should be having 3 hours of energetic play a day. So with some kids, we'll definitely do that naturally. You just give them a ball and a backyard, and they'll take care of it. But doing this stuff with our kids will make us healthier people as well. Especially for the preschoolers, 3 to 5 years, they specifically say that with regards to sedentary behaviour, that even quiet time, even if it's not physically active, it should still be sort of mentally active, and ideally doing puzzles and drawing, games and shapes. And if kids are doing this fine motor stuff, it means that their central tone is better, and that it means that their activity the next day is going to be better. So these, I think that no one ever comes home from a walk sad. No one ever comes home from a trip to the park sad, unless it's been cut short too early in my family's case. But 3 hours is a long time. A lot of kids do it themselves, but I feel that we, in my family, we have to plan this, and we do have to plan an energetic outing every day to make sure that we're sort of getting up to these guidelines. So I just thought these are national guidelines. I think that they're a good goal, even if they're not always achievable, like me today. But knowing that if we can do these things with our kids, rather than just for our kids, they're going to be healthier. And I think that that's really nice. That's probably enough from me on that one.
Awesome.
But we'll share the links to that.
Yeah, we'll definitely will. And if you want more information, we'll share a few links that you can obviously go and investigate a little bit more. So the next letter is S. So continue writing that down. All right, just quickly, if you can pop in we're going to chat about shoes now. So if you could chat in pop your answer in the chat box. What important features do you look for when buying kids' shoes? So if you can just pop your answers in the chat box. What are some of the things that you look for when you're buying kids' shoes? Barefoot sole, rad colours, I like it. Soft sole, arch support, durability, that's definitely a good one. Yeah, great. Do they like them? Yeah, well, that is a very valid question. All right, so just on footwear, obviously footwear is something that all of our children have to put on at various stages. And I guess we wanted to just touch on some of the things that we should be thinking about when we're looking at footwear. And it's going to lead in really nicely to Zara and Kate from Paperkrane to sort of chat a bit about their shoes. So the paradigms will be changed a little bit on shoes. I think previously shoes have always been mini adult shoes, whereas now we want to try and enhance that sensory feedback as much as possible to limit or unencumber as much as possible the foot so that the foot is allowed to develop naturally, but not also just the foot to develop naturally, but also to encourage the child to be able to walk and move around as unrestricted as possible. So we really encourage our patients and the children that come see us to be barefoot as much as possible. So when it's safe to do so, be barefoot. Obviously safe to do so means probably not outside on the street, but at home, take the shoes off, take the socks off, be as bare. Try and avoid socks without shoes. So obviously you can wear socks with shoes, but avoiding socks without shoes tends to impair traction. Kids are sliding all over the place. It obviously then can affect confidence. So trying to be barefoot. Obviously there's certain times of year where that may not be appropriate, but that's probably going to then sort of go into what some of the shoes that you should be looking at should be like. So minimal heel. We don't want a decent heel height on a shoe. It tends to obviously change the calf position, changes their biomechanics quite significantly. So this is something obviously we see typically in adult shoes. We want to avoid it in kids. Making sure it's soft and flexible so it can kind of follow the development and mobility of a normal foot. Light. And I've bolded that one because that's, I think, where shoes in the past have probably gone wrong the most. These big, heavy, restrictive shoes that a child's lugging around, it's going to have significant ramifications on their mobility and their development. So one of the things that we do want to look for in a kid's shoe is that it's light. Anatomically designed. So you can see over here, we've got a picture of a foot. We want to try and design a shoe that's going to, I guess, cater for the child's foot and make sure that it is actually designed to fit a child's foot as a child's foot grows. Uncushioned, we want to try and limit as much of that sort of numbing sensory effect that a really cushioned shoe provides. They may be more appropriate as we get older in certain circumstances, but in children, we want to try and reduce that or not have it as certainly as much of a feature as it is in adult shoes. Allowing the toes to remain flat, something with not too much of a forefoot rocker, or causing the toes to scrunch to sort of keep the shoe on. And we can't emphasize enough how important fit is. So obviously children's feet grow, but ensuring that the length and the width of a shoe is appropriate. And that's something that is worth checking every sort of 3 or 4 weeks. Toddlers' feet change a full size every 2 to 3 months on average. And an older child tends to be 6 to 12 months for a size. So these are things to be aware of. You also notice that in some instances, they may grow 2 sizes in 12 months and then half a size the next 12 months. So it's not always nice and reliable, but it is really important that one of the things that we can do to prevent a lot of foot issues and development issues just by making sure that the shoes they've got on are the right size, the right fit, and they follow some of the features that we've got here. Excellent. All right. Well, this leads into our chat with Kate and Zara from Paperkrane. So I won't sort of preface it too much because I'll let them talk. So do you want to chuck your unmute yourselves, Zara and Kate, and you can maybe put your hand up if you want to, who wants to start. But I thought we'll start off with just telling everyone why you started Paperkrane.
Kate, do you want to go first?
Sure. Basically, we started Paperkrane because we wanted to make shoes that were not going to do any harm to little feet, but also shoes that would stay on a foot, be easy to get on and off, and basically look still quite fashionable at the same time. So, like for me, like I love shoes. That was a big thing in starting it. But yeah, we sort of started with a little baby shoe like this and with an elastic ankle, and it's got a bit of paper in there, and you just slide the foot in and they go up in size to sort of bigger kids' shoes and that kind of thing. It's still easy for them. So yeah, but foot shaped, not going to do the kids foot any harm. They can still feel the ground, but yeah, easy to get on, fashionable.
And I guess further to that, what makes your shoes different from most other shoes that we maybe have seen in the past, or what we used to?
Okay, so with me, I've got 3 children. I've got a 12-year-old, an almost 10-year-old, and a 6-year-old. And I found it was always such a struggle to marry what I wanted in shoes, which was fashion. But then from really early on, it just never made sense to me when, you know, at the time it was get them supportive shoes, get them really supportive shoes with arch support and support. And I was like, that never made sense to me, because it just sounded to me like saying, put your child in a back brace now to prevent future back problems when they're older. It just never made sense to me. And what I seemed to gravitate towards were brands that did not offer all of this. And there was nothing around that was minimal and fashionable. So for me, that's where, you know, our designs came in. We wanted to sort of, as you can see in the picture, and I've got one of mine here, just to create a shoe that allowed a growing foot to be a growing foot, ultra light, ultra flexible, and really fashionable. And that's, you know, that's how it was born. And yeah, basically that's where we're coming from.
Great. And who's been involved in the design process? I know we sort of chatted a little bit about this the other day, but who have you got on board in terms of to help, I guess, discuss some of the features of a shoe and look at a little bit of what some of the research is telling us?
We work with several podiatrists around the world, and we are in consultation quite often with them. Basically, we worked primarily with them early on in the process when creating our sole. And we have an ultra light, 100% natural rubber sole, which is hollow. So this that you see here, there's actually nothing inside it. It's called a cup sole. So we developed this sole, and this was to us the most important part, because it bends like this, inwards like that, and it bends like this. And all of our shoes across the board, from small child to adult have this ultra bendy flexible sole. Now our early walkers, yep, Kate's lifted them up there. Kate, you want to talk about those?
Yeah, so these are just, they're even lighter. They've got what we call a midi sole. So it's got like a little rubber, really light rubber layer, and then sort of it's either got suede or the fabric around it, just as designed to give a little bit of extra grip, I guess, as kids are starting to walk or run, move a bit faster, and just give that basic protection if you're going to go outside and, you know, walk on something that's a bit sharp or, you know.
And the premise behind that is to essentially, you know, what was agreed back in my day, even when my eldest was little, was that when they're learning to walk, they should be barefoot as often as possible. And then shoes should only serve as protection from the elements and should allow them to mimic being barefoot essentially whilst wearing shoes. So that's where our midi soles come in. And then we decided, wouldn't it be great to create something like that for older children so they too could wear shoes which protected them from the elements, but also allowed their feet whilst developing to mimic barefoot walking. And that's where we brought in this flexi sole. And this sole we take all the way up to adult sizes now. And like I said before, this sole is the same across all our styles of shoes. So our Velcros, all the other stuff we have in development, it's the same sole across the board.
Yeah, great. And what you sort of touched on a little bit, but what's different styles of shoes do you offer? Do you offer school shoes that are appropriate for school, like a sort of a black?
Yes,
yep. We have two at the moment. We have two styles, and we've got two more arriving like right now with our logistics company. It's a bit hard to see in the so
sort of like a Mary Jane and a
style with a Velcro closure, and again just that super soft natural rubber, and then the biro. This is has elastic laces, so it's still a slip-on shoe. So they're all just really easy for anyone. And it's got
we actually decided to develop a school shoe in particular because this is where we see the worst shoe crimes committed in the school shoe market. They are clunky, heavy. You cannot bend them. They're like bricks. They've got heels. They're just, the more we became aware of this, the more we sort of targeted that school shoe market. And we've had a huge response to them in Australia and overseas, a lot in Europe and the UK, because there's really like nothing out there that's also affordable, healthy for their feet and also affordable. And that's the gap that we really wanted to bridge. It's really important to us because they spend so much time in school shoes in particular. And that was so important. So that's why we developed our school shoe range as well.
And what sort of price point are your shoes?
At the moment, they're $89 for the school shoes. So yeah, we've tried to, the average school shoe price is $119 for the sort of, your more well-known brands. And we wanted to sort of keep it as much below that as we possibly could to make it as affordable as possible for the majority of people. Because yeah, once you get into the sort of cheaper region of school shoes, you've got really, honestly, they weigh as much as a brick. It's just insane. So yeah, we really are trying to get them on as many feet as possible.
Yeah, great. And I guess last question is and you've probably discussed it a little bit, what does the future look like for Paperkrane? What are some things and ideas that you've got in the pipeline, or where do you see your shoes going?
Okay, so basically we would love to become a household name in Australia because we want Australian kids to grow up with healthy feet. And we now go all the way up to adult. And funnily enough, our adult shoes usually sell out within minutes. We can't keep up with demand because I think people are finding once they transition into barefoot style shoes, it's really hard to go back. And I myself, I cannot wear anything other than our shoes anymore. And it makes me feel so great that my kids are wearing them because I personally have experience now with the benefits that I'm feeling. from these shoes. So we're really passionate about targeting the Australian market in particular. We've got a huge market in Europe. They're very much into barefoot shoes there, and that's great. But our passions lie within the Australian market, and we're doing some amazing collaborations this year. We've got some really big stuff coming up with some amazing Australian artists. There's some really exciting stuff coming up. But yeah, that really is our passion. Get these shoes on as many Australian feet as possible, because we want foot health to be fun. So we're going to keep being crazy and fluoro and all the things that we do. But really, primarily, it is to get as many Aussie feet in this style of shoe as possible.
Yeah, great. And I think one of the reasons I've sort of wanted to chat to you guys is that, you know, if you look back at the conditions that Patrick and myself have discussed tonight, is that the common theme is that we want to obviously rule out any underlying pathology, but it's a case of monitoring. So it's not a case of providing treatments just for the sake of it, because it sort of may or may not be appropriate at that stage. The evidence is sort of suggesting consistently is that letting the child develop as normally and as naturally as possible, and this certainly does have a flow on to footwear. So thanks again for getting on board, and yeah, great to hear a little bit about a great Melbourne brand doing big things across the world in the shoescapes. So thanks again.
Thank you.
Here's the last letter. So if you want to pop the word into the chat box, we'll be in touch with you guys to sort of with the prizes. But I guess we thought we'd put it out to you if you've got any questions for either the team from Paperkrane, myself, or Patrick. Probably got time to answer maybe a couple of questions, and then, as I said, if you pop your questions into the chat box, we will get to you. So I'll share the questions with either the Paperkrane team, myself, or Patrick, and we will get to you. So please do send us some questions. All right. So has anyone got any questions? Okay, I've got one for the Paperkrane. I've got one for Zara and Kate. Where do you buy these shoes? Online, other stores? Good question.
So at the moment, in Australia, we sell primarily online. We are stocked by a few podiatrists, but primarily online on our website, which is www.paperkrane.com.au.
Yep, I've got all that there, and we'll send all these links out for the websites as well.
Thank you.
Someone has also said, are these shoes good for children that they need shoes with support? So I guess that's, again, comes back to the question, that's probably something that I can answer, is that it's probably a little bit more complicated than that. So we certainly can be placing little wedges in these sorts of shoes if they are required, and that's, I guess, having a bit of a discussion with the parent and the child. If there is some form of orthotic support, whether there's some bracing required, then these sorts of shoes can certainly work. Have you had experience with people making modifications to the shoes at various stages?
Zara. Yeah.
Yes. So my daughter was an in-toer, and I didn't know much about this at the time, and went to see a podiatrist and was recommended orthotics. Mm-hmm. And yes, they absolutely very easily fit within the shoes. We have heard from customers whose children have had various pathologies, mm-hmm. and yes, they can absolutely easily fit orthotics. So you're still getting the benefits of the light, flexible, comfortable shoe with whatever, personalization they require for their own, and another thing is we have quite a large following of parents whose children have sensory processing disorders, and their children tend to love our shoes. Again, very light, minimal interference. They feel more connected to the ground. So we've actually had an incredible response within sort of that market as well. And it's, yeah, that part warms my heart, because when we hear of children who have refused to wear shoes and won't walk, and then actually start walking when they get a pair of our shoes, we've had some emails. Yeah, we do get quite emotional, but that's, again, it's our passion really to get these shoes on as many feet as possible. And yeah. So yes, basically we can.
Excellent. All right. Well, we'll wrap it up there. I'd like to thank everyone for jumping on tonight. Hope you found some of this information useful. I think the main sort of take homes tonight is that if you do have any concerns, it's a really easy step to just come and get your child assessed. And as I said, the majority of the time, it's a case of doing a detailed assessment, understanding where this issue is coming from, and getting to the bottom of whether or not there's any further interventions that need to be done. I'd like to thank Dr. Patrick Doube for jumping on tonight and sharing his very valuable insights. He's based out at Bundoora, so great clinic out there. So if anyone does want any further information, as I said, I'll share his details. And thanks to Kate and Zara from Paperkrane. Great to see, as I said, a Melbourne company doing great things. And yeah, we've been sort of following you guys for a while, and think you're doing awesome things in the shoe space. So
Thank you.
thanks very much. Awesome.
Thank you.
All right. Have a good night, everyone.
Thanks, Andrew. Thanks,
See you
everyone.
later.
See ya.